Okay, well, welcome everyone to the trainee competition, and thanks for those of you who stayed on to watch this. This is a competition run by the college to get some ideas and sustainability from our trainees, and many were asked to provide submissions. A series of judges marked all these, and we've chosen the top 4 who are going to present short presentations today and then take questions from our judging panel. I'm delighted that we've 4 esteemed judges to actually make the decision who's the winner tonight. Professor John Brown, Chair of NHS GG&C, Dr. Emily Brutus, you've heard talk today, Professor Jeremy Bagg, Chair of the Global Health Group here, who's my chair, colleague, and the main webinar, and Nikki Philpott, who's Deputy Director of Greener NHS Programme and Director of UK Health Alliance and Climate Change. So what we're going to do is just run presentations one, and then the person will come on live and take questions from the judges for about 5 minutes, and then we'll do the second presentation and they will take questions, etc., to the end. And then we'll have a short break while the judges have a discussion about the winner, and then we'll come back just to hear the winner at the very end. So without further ado, I'm going to just present the first submission that was chosen for the final. This is by Amrital Sayan from the Leeds Dental Institute, Dental Core Trainee 2 in Restorative Dentistry. And the title of this is NHS Uniforms, an Untapped Avenue to Sustainability. Thanks.
Since the start of the COVID-19 pandemic, there's been an increase in the demand for scrubs and uniforms for staff and patient-facing roles. There are approximately 1.5 million staff working as a part of NHS England, and this figure excludes GPs and their team. Over 50% of staff are in professionally trained roles, which would need access to uniforms and/or scrubs. Whilst there is a lack of data, NHS Scotland disposes approximately of 1,230 tonnes of textile waste, which costs over £150,000, and there's also been a recent rise in landfill tax. Disposing in landfills requires space and also releases toxins into the environment, and therefore it is an unsustainable and an environmentally damaging route. There are several main issues that exist. The first is that there's a lack of standardised uniforms in the NHS across England, and this exists across specialties and grades. This means there's a lot of variance in textiles, dyes and designs that are used. NHS Supply Chain is, however, hoping to bring out a standardised uniform in the summer of 2022. However, there are still questions to what would happen to the current scrubs and uniforms in circulation. The second issue is that some trusts expect staff who bring their own uniforms to work to dispose of these themselves when they have left their role. It is also unknown how many trusts access local textile banks when items are at the end of life or when staff leave, what happens to these items after they go to local textile banks, and how many scrubs or uniforms are directly sent into landfill. The third is that the sustainability of materials and packaging used. Much of the packaging used is either plastic and/or cardboard. It's not always recyclable, or there may not be facilities at work or in the local authorities. Typically, the materials used to make the scrubs and uniforms are made of either 100% polyester or 65% polyester to 35% cotton ratio. We know polyester is a man-made fibre derived from fossil fuels, and we now know that when laundering, microplastics can enter the ocean from synthetic fibres. Cotton is also a water-intensive material and has had devastating impacts on the environment, for example, the reduction of the Ariel Sea. So what is the solution? The solution is the use of sustainable materials and overall a waste reduction implemented in several ways. My name is Amrital Sayan, and I'm a DCT2 in Restorative Dentistry at the Leeds Dental Institute. Initially, the project would begin by collecting data on why and how many uniforms and scrubs are in procurement. Is it because of new staff, the inability to repair scrubs, and more staff wanting to wear uniforms or scrubs? The second would be to assess current views by conducting staff surveys and discussion with key stakeholders. It'd be important to inspire others to see the benefit of this project. The third stage would be the assessment of current textiles in use, how these are procured with businesses who have access to the NHS, and also the types of packaging used by manufacturers. The fourth stage would be to evaluate the quality assurance processes that are used and to assess how garments are deemed fit for purpose and which ones are disposed of. The evaluation of different materials should also be considered, such as recycled materials, tencel, bamboo, and hemp. The next and final stage would be the implementation of the project, so working with managers, local textile companies, and all sustainable companies. So this diagram represents the life cycle of a garment, and if we start in the top left corner, it would first be important to see if current scrubs or uniforms in circulation could be repaired if needed to. This could be done in-house or by the manufacturer. If this wasn't possible, the next stage that could be considered would be to repurpose the uniforms and scrubs, and this could be done in conjunction with local textile banks. The third would be to consider alternative ways to prevent garments from ending up in landfill, and this could either be incineration, where the waste incinerated and turned into energy, or we could even look at placing microplastic filters on in-house laundry machines. This would also reduce the amount of microplastics entering the water streams and ending up in the ocean. The final point would be to consider ordering more sustainable uniforms and scrubs, and either those could be new novel materials that have less environmental impacts or recycled materials. In summary, the cost of the NHS of disposing textiles is increasing and has a huge impact on the environment and our healthcare. The solution is to consider repairing, repurposing and disposing in less impactful ways, and also addressing the problems of packaging to further reduce the waste that goes into landfill. Thank you for listening.
I'm John Brown from NHS Greater Glasgow and Clyde, and as a stakeholder in this, I'm sold on it. Well done. I think this is an excellent project to be proposed, and an even better project for someone to get off the ground. And I heard what you were saying about the barriers in response to Emily's question. You mentioned stakeholders and how you convince stakeholders, and of course the best way to do that is with evidence. So I'm interested in just hearing a wee bit more about your evaluation criteria. You mentioned two in your presentation. One was about the cost of disposal. The other one was about the environmental impact. Have you given any more thought to what other criteria you might use to evaluate the project with a view to using them to convince people to adopt this new approach?
Yeah, so in terms of like trying to get more sustainable materials ordered, we need more scrubs. There's actually a really good index that's come out from the fashion industry called the Pig Sustainability Index, and there's like sort of 5 parts to it that would be a good way to encourage people about why it's important. This part looks at the amount of water that's used in creating the crop that we're going to be using in that material. The second looks at the global warming potential. The fourth looks at the fossil fuel depletion that could be resulted from using It's a really good index that's currently being used in the fashion industry, for example, to try and show like the benefits of use. Could they then be used for like insulation mats? Could they be used in car seats manufacturing, like the padding that's used inside? So there's all these alternative methods that could be used. And I did come across Milton Keynes actually in 2014 of their textile waste. They got paid per kilogram for their textile waste. It's not known how much they got paid for it, but that would be a great way of sort of showing stakeholders what are the other alternatives rather than disposing of them.
Thanks, Amritpal. Just like Emily and John, I really liked this project. One of the things I just wondered was whether you thought about the source of these scrubs, because of course many uniforms are made overseas, often a long way overseas, and whether or not the source of purchase and production was something that was worthy of consideration or not.
Yeah, but the issue within the fashion industry is that the UK doesn't produce any of the crops that are used in scrubs. So cotton's always going to be abroad, polyester is going to be abroad. Well, hemp can actually be grown anywhere. It's quite a versatile material, low in its water usage, and it's also really great in terms of nutrients it gives back to crops, to the soil that it's grown in. So actually that is a material that in the future could be grown here, climate conditions. But you know, even looking at other materials like bamboo, that's going to be a. So I completely understand your point that carbon emissions related to transport materials and the countries are coming from. But at this stage, pretty much everything that we use in terms of clothing in this country, as a raw material, it's not made in this country. We may buy that fabric from another company and then make it here. So we make the garments, but I mean, there's not really a solution yet to that. But I think, you know, there are novel materials coming out, even with the recycled materials. yeah, we could dissolute them, or we could put them down to their raw fibers in this country, but often stored in other countries because it's just cost of labor so much cheaper. So then you're looking at the ethics of the companies that use their workers, and if that's possible to have that labor done here with the technology.
Okay, that's fine, Amrit. I got most of that. Thank you. That's the end of my questions. Thank you. So I think we'll probably, that's it for now, Amrit. I was the last one to ask a question. Thank you.
Okay, thanks very much, and well answered despite a few technical issues there. So we'll just move on to our next finalist, and this is Megan Quinn. Megan's an FY2 in NHS GG&C, although currently working in obstetrics and gynecology at Wishaw. And the title of her presentation is Travel-Related Carbon Emission Savings in Immediate Sequential Bilateral Cataract Surgery, a Global Health Solution. So over to Megan.
Good morning, everyone. My name is Megan Quinn. I'm a junior doctor in Glasgow currently. And firstly, I would like to say thank you for being given the opportunity to present some audit findings that I've been recently involved in. Today, I would like to speak to you about immediate sequential bilateral cataract surgery and the travel-related carbon emission savings in such a procedure. Before we go on to describe the audit, I would like to firstly describe immediate sequential bilateral cataract surgery, or ISBCS as it's known in its shorthand. ISBCS, as the name suggests, refers to a patient undergoing bilateral cataract surgery in the one sitting. It's been known for about 10 to 20 years. It's not new, however, due to sort of lacking in sufficient evidence regarding the safety of such a procedure, it's not routinely offered by the NHS. However, the NICE guidelines in 2017 stated that patients should be given information on ISBCS if the physicians involved felt that it was appropriate. However, again, it wasn't until the coronavirus pandemic in 2020 that the Royal College of Ophthalmology released guidance on ISBCS, as it was acknowledged that ISBCS can reduce patient contact with the health services. And more recently, as the idea is becoming more formulated and it's becoming more actively routinely offered in the NHS, a survey was done in 2020 with 267 patients, which showed that 45% of patients are open to the idea, which goes against previous findings. Through my time studying in Inverness, I became aware of the limitations of healthcare provision in rural areas, and because of this lack in provision, or difficulty in providing services, it meant that ISBCS has been offered in these areas sooner than in other areas of the UK. This audit was carried out second to an initial audit in the Western Isles off the west coast of Scotland, which involved 10 patients. Our team recognised the importance of environmentally sustainable healthcare, and we wanted to investigate ISBCS and its relation with travel-related carbon emissions. And we felt that through investigating one small carbon-producing element in the cataract surgery pathway, we could provide more information and more indication, and another reason to promote ISBCS, and also to promote carbon savings in the environment today and to help with the ever-increasing global climate crisis. To do this, we wanted to investigate a larger patient database, and through that we moved to Orkney, up in the north of the Scottish coast. It was at this point that the team decided that we would calculate carbon travel savings, and through this we used a UK government carbon conversion factor to calculate these costs. The savings were calculated as patients had one reduced journey to the hospital for an operation, and additionally they had one less post-operative check. There was a subset of patients that had an additional appointment because these patients underwent bilateral cataract surgery during the coronavirus pandemic, and they therefore required a preoperative PCR test. In this patient group, we had around 102 patients. So in this patient group, we had 102 participants, or 102 ISBCS operations. There was 59 females and 38 males. And on average, there was 8.8 kilograms of carbon greenhouse gas emissions per participant saved. 34 of these participants had ISBCS after the UK COVID-19 lockdown, and then this subset, as I described previously, who had an additional appointment and 3 additional appointments versus single cataract surgery, these patients had 14.2 kilograms of carbon emissions saved. One of the main concerns regarding ISBCS is the complications that can be associated with such. For example, endophthalmitis. These complications in this study of 102 patients were above the National Ophthalmic Database of audit averages, and we feel that this is another indication to produce ISBCS. More importantly, to produce ISBCS and with its relation to carbon savings. We feel that ISBCS could be beneficial in the tackle to providing the NHS to be environmentally sustainable in the future. Cataract surgery numbers are increasing due to the ever-increasing population, and demand is only going to become greater. And if we can reduce one small carbon-producing element, we can reduce the overall carbon emissions from such a procedure. I think further study could be conducted to calculate carbon savings in ISBCS through environmental factors within the hospital and equipment used. Thank you for listening today. This is a list of references that I've used in this presentation, and if you have any questions, I'd be happy to take them.
Thanks, Megan. And the judges are joining you, and I'll leave them to quiz you for 5 minutes.
Thanks very much, Megan. And I'm really glad that we've had this part of the evening, because it's really inspiring to see young people coming through and with all these ideas. And, you know, you're an FY2, you're 2 years out of university, and I think it's just so lovely to see that already you're on this climate action journey so early on in your career. So really well done. My question for you is, you've demonstrated this in a health board where patients are traveling long distances, and it's a really great piece of work. I really love it. What do you think would be the barriers to trying to roll this out across Scotland, and the challenges that you might have from busier health boards where the patients are not traveling such long distances? Are there other things that you could perhaps look at that might be able to convince them to take this on as an option?
I was just saying, firstly, thank you for your question, and I think definitely it's an important question to flag, and it is something to consider, as we know that the majority of the population aren't living in these rural areas. I think when we done our study, we appreciated the limitations of trying to compose such findings, and we were trying to think about what we could evaluate. I think we had an understanding that waste is primarily the greatest source of carbon emissions in the NHS, and what we were trying to do was to sort of routinely show that even just something simple as travel can have savings. And if we can show that travel in these smaller areas can have savings, if we were to then further this study and actually start to think about the environmental factors within the hospital setting, the equipment that's getting used in the urban areas, these are the same considerations that will be in the rural environment. The equipment that's used in these procedures doesn't change in the landscape. And I guess our findings would be that we would feel that services would begin to start to consider this. I think the barriers will be both at a patient level and at an industrial level, or an organisational level, sorry. And that's purely because it is something that's new. And I think it's been able to educate both professionals and the public about what we're offering, and it's about giving informed decisions and about primarily seeing what people's thoughts are on it. But ultimately, I can understand that travel maybe isn't something to consider in the urban environment, but it's the other carbon savings that are associated with this procedure that we can assume, and I think we could go on to find.
Super. Thank you very much. And I think you were touching there on realistic medicine and bringing that patient along in the journey, which is really lovely to see as well. Thank you.
Thank you, Megan. John Brown up next. Again, I really like this. I actually particularly like how you're linking what was originally seen as an improvement in patient care and actually looking at how that can be enhanced to use that change to secure a reduction in carbon emissions. And I also like the idea of looking at one part of the Scotland, the rural part, the islands, but thinking, how do you roll that out? We're very big about how do we have a once for Scotland approach? How do we learn from best practice from the islands to the cities and vice versa? So now this project's got a lot going for it. Question for me though is sort of following up a bit in Emily's point, which is around this: what does good look like? What would success feel like? And using that to persuade other health boards to adopt this particular practice. So you've already got criteria around improved patient care. You've got some criteria certainly around carbon emissions. Have you thought of any other success criteria, any other selling points, I suppose, that you might investigate?
No, of course, and thank you again. I think given the sort of climate that we're in at the moment with our healthcare service, due to our pandemic that we've sadly all experienced over the past year and a half, we know that every day in the media we're getting spoken about different targets that healthcare services are being expected to meet. And I think primarily we could put it down to this is reducing carbon costs, but actually it's reducing the number of patient attendances that you're having to commit to in the hospital. And that would be, I guess, my main selling point, that you can reduce 2 operation slots down into maybe one slightly shorter one. And the combined time of maybe doing both eyes in one sitting is going to be less than the total time of 2 separate operations. I think that's one thing to consider among many others.
No, that's an excellent one. Improving the throughput is something that most chief executives would bite your hand off for. Excellent.
Thanks, John. Hi, Megan. Yes, lovely project, and congratulations on your presentation. You communicated it extremely clearly. I'm going to actually ask you a question from one of the other judges who couldn't actually be here tonight in person, Nikki Philpott. And she's asked, does having bilateral cataracts increase inpatient stay? And if so, is the carbon footprint of this included in your study?
Okay, so I think firstly what I would say is that given that I am still a trainee, I will hold my hands up and say that this isn't something that I've looked into in a lot of depth, and I think that's all you can do when you maybe ask something that you're not 100% clear around. My understanding from it is that patients are counselled on the fact that they will be having both eyes done, and with that comes reduced vision in both eyes. And from the islands, what they were asking patients is, would you have someone safe to take you home? Or would someone be able to drive you home? Now, I guess our understanding would be that we made the assumption that patients would be driving with whoever was driving them home. Now, that may not be the case, but that's something that we think is probably most likely, whether it be a relative or a friend. It doesn't, bilateral cataract surgery on its own isn't an indication to have to stay in hospital for longer. You're at the same risks as single cataract surgery. The risks tend to be the long-term development of potential complications, which have been investigated. And it was a slight slip in the tongue during my presentation to say that our complications were higher than the averages, but actually they were lower. And I think the National Audit for Ophthalmology, the database in 2020, had said their complications were 1.14% for posterior capsule rupture, whereas in our findings it was 0.5%. And I think we haven't considered factors if patients are having to stem for complications, but we're showing that the complications are being reduced, and we'd hope to investigate it further.
That's a good answer. No, thanks very much, Megan. That's the end of my questions. Thank you very much. Thank you.
Great, thanks very much. So we'll maybe move on to our next presentation. Just as Jeremy said there, Nikki Philpott's not been able to join us live, but she is marking these presentations, and her marks will be taken into account when the judges decide at the very end. So our third presentation is from Dr. Rishi Trivedi, an FY1 doctor in respiratory medicine, East Sussex NHS Trust. And Richie's talking on electric ambulances, a lifeline to a greener NHS.
Hello everyone, my name is Rishi Trivedi and I'm a Foundation Year 1 doctor. I'd like to welcome you to my presentation for the college's Trainee Climate Change Competition. The proposal is entitled Electric Ambulances, a lifeline to a greener NHS. So, without further ado, let's begin. Firstly, a bit of background. Climate change is a significant crisis that not only threatens our livelihood, but carries health impacts including heart disease, cancer, asthma, and stroke. Unfortunately, almost 30% of preventable deaths in England are due to non-communicable diseases, specifically attributable to air pollution. More than 200 hospitals are in areas affected by air pollution, and to make matters worse, the NHS is itself responsible for upwards of 20 million tonnes of carbon dioxide production annually. With particular reference to road travel to and from hospital premises, it is estimated that we cover almost 10 billion miles in a single year. With hospital admissions rocketing during the pandemic and predicted to further increase this Christmas, there must be a seismic shift in attention aimed at tackling this climate health emergency. So I ask, what is the solution? My intervention proposes the rollout of greener electric ambulances. In particular, cutting air pollution and mileage from ambulance travel has the potential to accelerate the UK's ambition to achieve net zero carbon emissions by 2050. The benefits of electric travel have been well documented, most importantly, the lack of emissions and carbon footprint. In addition, electric motors have a low maintenance in terms of cost and service. In a traditional combustion engine, there are hundreds of moving parts which can potentially go wrong, whereas an electric motor has fewer than 20. This means more miles on the road without breakdown. Performance is also greatly increased, meaning navigation and acceleration within busy city centres is greatly improved. Also, once the lifespan of electric batteries has been reached, it is now possible for them to be recycled. Metals such as lithium and nickel can be processed and converted into a usable form. This has already been demonstrated at Volkswagen. So, you may ask, is this achievable? I say 100% yes. On a 12-hour shift, ambulance crews within city centres average 80 miles. As rapid charging is introduced and battery life is extended, ambulances will be able to travel upwards of 250 miles on a single charge. Electricity carries the benefit of it being a renewable resource. This is particularly relevant with the recent fuel and HGV driver shortage. There will no longer be a problem with supply. In terms of cost, rising fuel prices have resulted in ambulance services spending upwards of £350,000 on diesel in a single month. This is before maintenance costs have been factored in. With electricity costing as little as 4 pence per mile, the significant fuel savings can be used to fund additional equipment or even the training of another paramedic. Lastly, ambulance crews will not be faced with the prospect of further training. Ambulance design will be preserved, and so too will patient care. In fact, quieter and smoother drives will likely enhance the crew's ability to perform potentially life-saving procedures within the ambulance. So, with the UK government announcing a ban on all petrol and diesel cars by 2030, it is important that the emergency sector and NHS follow suit. The successful implementation of electric ambulances has already started in the West Midlands in 2020. Additional trusts must follow suit. While the NHS is already a world leader in sustainability, as the biggest employer in this country, comprising nearly a tenth of the UK economy, we have long been both part of the problem and part of the solution. The world is changing and the NHS must keep up. Only then can the NHS comply with its duty to first do no harm. I shall leave you with a quote from Greta Thunberg, who once said, "I want you to act as though your house is on fire, because it is. We must act now." Thank you very much.
Thanks very much, Rishi. If you join us on screen, that's great. Over to the judges then for a few questions.
Hi Rishi, thank you. You guys are making this really difficult for us tonight. And also I love it. I just really love the fact that you are 1 year out of uni, you're just into the health service working, and already you're just finding this stuff out. You're speaking tonight with, you know, such knowledge that you've already just gone out and you've looked at this problem and you've sorted it out. But I'm reflecting back to what I mentioned in my talk about that feeling of being disempowered, about how do you actually then make this change, you know? So here you are as the doctor, you're not responsible for turning the ambulances into electric vehicles as far as I last checked. So what is going to be your next step tonight, tomorrow? You know, who in your hospital you speak to about this, and how are you going to go about it to enact this project?
Yeah, thank you very much for the question. I think as with all startups, it does require quite a bit of investment, and hopefully with government funding, this can be something that can be achieved. So, I mean, with the Transport Secretary recently announcing sort of a £120 million fund to help local transport authorities introduce zero-emission buses, hopefully the government will also fund the majority of electric ambulance fleets going forwards. And I think with Rishi Sunak also announcing his recent budget, some of that £6 billion invested into the NHS will hopefully be used to support our ambition of becoming net zero by 2050. So NHS Scotland have actually already seen a benefit from this, with £1.36 million worth of money being put aside to support greener vehicles across NHS Scotland. So, I mean, the startup cost is always going to be more than that of traditional combustion-powered engines, but hopefully this cost is going to be offset by the savings accumulated during the lifespan of an electric ambulance. So I think the main thing is it does have to start within the trust, but as a whole, the umbrella sort of term, I mean, the government has to be responsible for this, and especially with the funding.
Thank you.
Hi, Rishi, John here. Again, I really like this. What I particularly like about this, it's making the point that where you have the right thing to do, move away from petrol and diesel, the NHS should be taking the lead in it. As we've seen from the presentations earlier today, the NHS is a big player in this country, in the environment, so we should be at the forefront of it. So this whole idea, to me, is spot on, and looking at our ambulances is the one that will capture the imagination of the public and everyone else. It will really set a strong signal as to what's the right thing to do. If the clinicians in this country say, let's go electric, let's start with the ambulances. So I like that. So picking up on Emily's point about how do you convince people and how do you take it forward. So let me ask you a wee bit about implementation. Yeah. So how would you see us implementing this? Do you favour a big bang approach where we try and divert monies that we've got to do it big time? Yeah. Or do you see it more as a rolling programme across the country as individual trusts find the money as they come to replace things? What do you think's the most preferable rollout strategy, and what do you think's the most realistic? Are they the same?
I think probably the most realistic and preferable would be within trusts themselves. I think, as I said in the presentation, it's already been seen in the West Midlands. I think other trusts need to jump on this bandwagon and follow suit. I think probably the one question trusts may ask is what's going to happen with these old combustion-powered ambulances? Are we able to sort of convert them into electric ambulances? So usually the lifespan of a single ambulance is about 7 years. And if we stop producing these petrol and diesel ambulances now, we can still meet the government's target of no further combustion-powered engines by 2030. So another thing that might be an incentive for trusts where they can also save money is that the equipment within these older ambulances can also be recycled. So observation machines, cardiac monitors, oxygen cylinders, they can all be reused. And then just the external shell of these old combustion-powered ambulances, they can also be recycled. So they're made up of 75% of metal, and these can be recycled instead of going straight to landfills. So all these small measures can help not only trusts save money, but also help with the rollout within each area.
Great presentation, thank you. The question from John and your answers actually covered a couple of points raised by Nikki Philpott, who's the other judge who couldn't be here tonight, so that's great. What I wanted to know is if there's any feedback yet from the West Midlands rollout, because you were saying that started in 2020. It's still early doors, but perhaps one of the ways of convincing trusts to do it would be with some very positive news from a trust that has done it. And I wondered if you had any intelligence on that.
Yeah, so I did have a look, and they interviewed the paramedics who are driving these new ambulances. And on the whole, it was a really positive response. So not only they don't need any further training. There are no gears. Obviously, it's just an accelerator and a brake. So that means they can focus all their attention on navigating busy roads.
Also, in terms of patient experience in the back of an ambulance, it is a lot quieter, it's a lot smoother. So hopefully this will also help paramedics carry out certain procedures, and sort of this is where the care begins in the ambulance. It should begin in the ambulance before they reach A&E. So on the whole, the response has been really good in the West Midlands.
Okay, so some good, robust information from that file would be very useful for others. That's great. Thanks very much, Rishi. That's the end of my question. Thank you.
Thank you.
That's great. Thanks very much. So we're just coming towards the end. So I'm just going to present or introduce rather our fourth presenter, our fourth finalist. And this is going to be Stephanie Lipp, who's at Queen Elizabeth University Hospital here in Glasgow, an ST doctor in clinical pharmacology, therapeutics and internal medicine. And her presentation is on carbon-informed clinical decision support for net zero blood pressure study. So Stephanie, all yours.
Good evening. I am Dr. Stephanie Lipp, who will be presenting our proposal entitled Carbon-Informed Clinical Decision Support for Net Zero Blood Pressure, CINDA-BP. Hypertension is a chronic disease that affects 1.5 billion adults globally and 1.2 million adults in Scotland. It is a disease that requires lifelong follow-up and treatment. Hypertension drives carbon emission, which has a direct impact on climate change, primarily from suboptimal blood pressure control, leading to increasing patients' travel for attending clinics and outpatient investigations, often separated in space and time, and this has impact on the NHS via service provisions and hospital admissions. The effect of climate change can cause increased pollution and socio-economic disruption, and this can promote hypertension. Climate change also has effect on both patients and the NHS through the social and environmental determinants of health. Hypertension is at the start of the cardiovascular continuum. It is a risk factor alongside diabetes, high cholesterol, and obesity, which progresses to coronary artery disease, leading to end-stage heart disease. From my previous slide, I have mentioned that hypertension contributes to climate change and its amplified carbon cost because these patients require greater interaction with NHS provisions. The x-axis on the graph shown is the cardiovascular continuum conditions, and the y-axis is the estimated carbon cost. The black line is a simplistic notion that as an individual risk factors develop cardiovascular conditions, the estimated carbon cost will increase exponentially. The triangle at the top shows that there is a large proportion of the population at the early stages of the continuum, and the carbon cost for treating these patients is low. However, the blue line is representative of the actual carbon cost in real life, flatter as even though there is a higher prevalence of risk factors per individual is high, the actual prevalence of disease is actually lower. The blue dotted line is what happens with the current measures to reduce carbon emissions in the NHS. For example, recycling, reducing transport, but this is only going to produce a small reduction and we are not going to achieve net zero. We can only achieve net zero where carbon savings are integrated into patient care, bearing in mind that patient care and saving lives cannot be negotiated with carbon cost. This is conflicting with the Hippocratic Oath, where as doctors, we are told to do no harm. For clinicians to change practice, guidelines have to be based on evidence, and what we propose is to integrate carbon savings into the current healthcare practices by conducting a robust clinical trial. Our proposal is to first calculate the carbon footprint associated with hypertension management. Our study design is based on real-world analysis, where we look at primary care and secondary care data. The Glasgow Blood Pressure Clinic, which is part of a secondary care, has more than 10,000 patient visits per year and covers a 20-mile radius, a large geographical area, and a typical patient journey is shown where there are multiple hospital visits. We will then use record linkage to classify patients into 5 groups: untreated hypertension, treated controlled, and treated uncontrolled in patients with no comorbidities and with comorbidities. For the untreated hypertension group, we assume that because they do not utilize healthcare services, their carbon cost will be low. However, those treated hypertensive patients will access healthcare and thus their carbon premium will increase. We expect that in the treated controlled hypertension group, we cannot reduce carbon costs and carbon premium will need to be paid. To explore this further, we can conduct a clustered randomized trial based on GP clusters using a digital-based intervention. This will involve a rich spread of data consisting of socio-economic status and comorbidities. There is a control period time before intervention, which is the implementation of the app. Follow-up will be at 6 months, where we can look at the outcomes, which is carbon savings per millimeter per mercury reduction in blood pressure. We have presented a digital carbon-informed solution for hypertension that will generate Class 1 evidence that would be acceptable to clinicians to change practice towards sustainable working in the NHS. Our hypertension example can be scaled to other chronic disease to achieve NHS net zero goals by 2045. Thank you.
Thanks, Stephanie.
Yeah. On you go. No
Sorry,
problems.
thanks, Stephanie.
Take care.
Thanks, Stephanie. That was another brilliant presentation, and well done on your slides. They were really, really impressive there. You've laid that out so well. And, you know, talking about doing trials, you know, in the context of climate, it's lovely. It's lovely to see. So well done for that. It looks like a really huge amount of work. So thank you. You're talking about your outputs, and you're specifically, obviously, the relevance here is climate. So you're talking about carbon reduction. The sort of the aspects of digital interventions in patient populations that makes me twitch sometimes is around the increase in the health gap that can occur. And I'm sure you're aware of what I'm talking about. You know, what about the population that don't have easy access to, you know, mobile devices that would allow this, or even the literacy around using mobile devices. So you mentioned in your data capture that it was going to include socio-economic data. Do you have a way of keeping track of, you know, the engagement and how you can facilitate people from backgrounds that are not able to engage as easily?
So I think before even conducting the trial, what we need to do is probably having a pilot small study where we involve people in the socioeconomic spectrum, especially those who are of ethnic minorities, for those who are well-used smartphone user. To see whether there's anything from their perspective, because in my practice, it's always best to speak to the patient because they actually know best, more so than the doctor. And I'm trying how to adapt the technologies to actually fit their needs, and also to get and create a digital app which actually intrigues people to use. No one would use an app which is dull and sends you 1,000 notifications every day compared to maybe one or twice. But I think it's to finding a happy balance to see what can actually reach people who are not unable to use a digital smart app phone properly, but that can be through education, having small focus groups actually in the GP cluster to see this is how it works. Is there anything you want to tweak it to make it user friendly? There'll be a lot of testing needed for, you know, to reach the kind of population that we want to.
Thanks, Stephanie. Yeah, and I guess it's crucial, isn't it, about finding in those focus groups the people that are going to risk you widening that health gap that we see. Thanks, Stephanie, for your answer.
Stephanie, I'll go next, and then John will come later when he's rejoined. So yeah, thanks very much. Excellent presentation. I've got some questions from Nikki Philpott, one of the judges who couldn't be here in person tonight. And one of the things she says is, you mentioned current interventions. Do you think measuring how effective current carbon saving interventions are, for example, how many people are actually doing this, and should that be looked at as a first point of call before introducing new interventions?
Yeah, so based on proposal 1, that's how we are going to address it, by looking at retrospective data and also combining it with the safe haven data set that we have to actually see whether there's actually a difference before we implement the trial. Of course, basically, we would like to encourage clinicians to use, you know, encourage people to how we actually going to teach clinicians to integrate, you know, climate emissions and, you know, think about climate change into their own practice. So even to convince people, not only the patients, but also doctors, to see that this is going to be evident. If it generates evidence that we need, then doctors will change practice based on trials rather than changing out of a, you know, prospective kind of study. So we need to change both mindsets, just not one person. So
yeah, that's great, Stephanie. And maybe I could ask one more of my own. I'd like to know a little bit more about the app that you're planning. Having had a bit of involvement with developing apps in the past, it's not straightforward.
No.
And I just, if you could talk a little bit about how that would be enacted.
So it's like an idea. I know there is different ways on how to create apps. Then also there's different companies. So it's always quite challenging to find the app which suits most people. And also it's lots of discussion basically. But in my head, I do know how I like it to look like. If I was a patient, I probably would not want 10,000 notifications a day. I'll
Right.
like something which is actually more personalized to me. Maybe it says, Stephanie, I've not walked 100 steps today. So the app will be like nudging you, like you are been sitting at your computer at endless Zoom meetings. You have not moved from your desk. So it's like simple things which actually personalizes to encourage use rather than hinder use. So I think it's something to think about.
Okay, thanks, Stephanie. I'm going to ask Adrian if he'd like to join us, and because I think John is having real connection problems this evening, and I think we should probably try and do the next bit with John on WhatsApp. I don't know what you think, Adrian.
Yeah, no, I agree. I think that really wraps up the questioning and the 4 presentations. So what's going to happen now is the judges will all go to a special room where they'll thrash out the winner and add up all the scores. And the answer should be available in 5 minutes, I reckon. So if people don't go too far away, grab a quick cup of coffee or something, and we'll be back basically 5 minutes from now. And we'll be able to announce the winner. So it'd be great to as many people as possible come and just watch that. So see you shortly.
Thank you.
Okay, so we're back on screen. Thanks everyone for waiting, and I'm just going to hand over to Emily, who's going to announce the winner of the prize.
Okay, thank you very much. So firstly, thank you to all of you. We've said it during the presentations. I mean, they were such high quality. You gave us a real challenge in trying to pick a winner among you. You've encouraged us. I really am really grateful for the effort you've gone into this. You've educated us all. You have inspired us really to to go back. I think everyone here tonight was going to go back to their own health boards and say, what are we doing with uniforms? What are we doing with ambulances? And these are really good projects and really good thought pieces. So thank you. Ultimately, we did have to pick a winner. We have deliberated backwards and forwards because it was such a challenge, but ultimately we've come down on the winner, reflecting both on the fact that we liked the aspect of thinking about the patient themselves and the patient experience, and we liked the fact that you had looked at a patient outcome and then translated it into climate benefit as well, which was really nice. And so ultimately we came down on the project that Megan presented, looking at bilateral cataract surgery. So Megan, I wonder if you could join us. Congratulations. Are you able to turn your camera on? Thank you, Megan.
Well
so
done.
Congratulations.
Well done.
And with the others all oh, sorry, Adrian, I'll hand over to you.
Megan, the prize is a £250 voucher to be put towards your project, and maybe in 6 months you can give us a short update of where you are on that. That'd be very helpful. But congratulations, well done. And as Emily said, if the others could join us, if Amrital, Rishi and Stephanie could also join us live on the screen, that would be great. That's fine. Just wanted to say thank you to everyone for all the work they've put into this, and thanks to the judges obviously as well, and indeed to all the speakers in the earlier webinar in addition to the trainee competition. And I'd also like a big thank you to Lauren, Karen, Paul, Andrew, Cliff and all the team at the college for doing all the work to put this together. It's been a long evening, but I think it's been really inspiring, as Emily alluded to, and we've learned a lot, and we're very much looking to COP26 over the next 2 weeks, how it pans out and what the conclusions are. So thank you very much to everyone, and enjoy the rest of your evening. Thank you.